Alrighty, good afternoon and welcome to another session of Executive Insights sponsored by the WKU Graduate Programs and Outreach Center. We want to thank each of you for the time that you have committed this evening to hearing from one of our amazing presenters. And what we like to do is just encourage our students, which are in any of our graduate programs, whether it's econ, whether it's MBA, whether it's cybersecurity, data analytics, or accounting, just to think outside of the box. We're going to have our presenter, who I'm going to introduce to you in just a moment. She'll speak and give a presentation. We'll offer time for Q&A. And then, as always, each month we will post this to our Executive Insights portal for you to view at your leisure. Right now, we'll go ahead and jump right in if that's okay for you all. I would like to introduce to you all Miss Melissa Wade. Melissa Wade holds a MBA and is a certified healthcare financial professional. Melissa currently serves as the Director of Financial Operations for Baptist Health Paducah. She has worked in consulting, healthcare manufacturing, and county health departments, but the majority of her career has been with the healthcare systems. She has successfully mastered skills in financial analytics, decision support, budgeting, forecasting, operations, and has been an integral part in multiple implementations throughout her 20-plus year career in healthcare. She has served as a local member of the county health department, elected school official, and currently serves on the Kentucky HFMA board and on the ACHE local program council in her region. Outside of work, Melissa enjoys traveling, hiking, boating, and investing in young people through her local church. Without further ado, Melissa, the floor is yours.
Thank you, Kenzie. So happy to be here with everyone. And so I think Kenzie had given my introduction. So I will actually, we're going to start our presentation day today with HFMA and the introduction for that. And I'm going to let Haley Howard, who is our HFMA Kentucky Board President, present those few slides.
Hi, everyone. Thank you, Melissa, for passing it off to me. Like Melissa said, my name is Haley Howard Baker, and I am your current Kentucky HFMA chapter president. I actually work at Forbes. Forbes is my day job. I work in our healthcare consulting department. But Forbes as a whole, we're an accounting and auditing firm. Some of you might recognize us. We're formerly BKD. And then we went through a merger and we are now Forbes, which is short for Forward Vision. And we're actually about to go through another merger again, but that's what I do during my day. And then in my spare time, which is not much, I am your Kentucky HFMA chapter president. And I just want to say thank you for letting us come and speak to y'all. HFMA is how we got connected and ended up being able to speak with y'all tonight. So we just wanted to touch on a little bit about what HFMA is. So HFMA stands for Healthcare Financial Management Association. And the whole point of our organization, it's a nationwide organization, and you can join as a member. And the whole point is to, help with education and networking events for all of our members. So here is a little snapshot to see our professional membership, that we have over 100,000 members. And that's actually as of last year. So we've grown since then, but we are all across the United States. Every single state has their own chapter for different members to get involved in. And I think our Kentucky chapter, Melissa, correct me if I'm wrong, but I believe we have over 1,000 members. We might have hit 1,100 members.
It's close to 1,100.
Yeah. So, and that's just for our Kentucky chapter alone. A little snapshot of our members and their career stages. So on the left, you can see about 60% of our membership is at the professional level, and then 24% is a director mid-level, and then you have 10% executive level. And then on the right there, you can kind of see the makeup of HFMA as a whole. So heavy revenue cycle, finance, patient access, patient financial services. And as I've mentioned, it is healthcare and finance related, but there are a lot of folks who come into this healthcare financial management space without healthcare background. A lot of them come in with their MBAs or perhaps, data analytics. It's not necessarily all hospital and health system folks. There's a lot of people, for example, myself on the accounting side or the consulting side. There's a lot of other vendors and a lot of different businesses and organizations that go into healthcare. So if you are or are not interested in healthcare at this moment, don't close your mind. I would suggest keep an open mind because you never know where you might end up, and healthcare will always be here. And so the last little bit that I wanted to touch on is the benefits of our HFMA membership. So a lot of folks join, as I said, for the networking and the education. We provide professional certifications, which are free to all of our members. We have 8 different certifications now that you can take, and you can, you can make your own study plan, take it at your own pace. And then that's something that you can carry with you going forward. There's different e-learning courses and webinars. The community groups, that's a really big thing for like-minded individuals to connect. And then you can get as many or as little communications as you want with newsletters and mailers. So a lot of networking and a lot of education opportunities. And if anybody is interested in healthcare or finance at all, please feel free to reach out to me and come to our events. We have an event coming up September 26th at the Kentucky Derby Museum. So you are more than welcome to come as a student, and we'd love to meet you there. So thank you all for having us, and please don't hesitate to reach out with any questions.
Thank you, Haley. And this is Melissa again. And so, today we're talking about healthcare analytics. And for some of you that have maybe been involved in healthcare or have not been involved in healthcare, hopefully this will give you kind of an idea of what healthcare analytics means to organizations and how it not only analytics helps us in a financial way, but also it's a common goal that we have through analytics to improve quality patient care that's a cost effective. And so healthcare analytics does that for us. And so, one thing about healthcare analytics, there's a lot of data out there. It's very unwieldy. It's not normal. There's a lot of unstructure there. And healthcare analytics, it can be comprehensive for a single patient. Could have everything from an electronic record data and physician notes to imaging, prescriptions, lab results, insurance, monitoring of equipment, and even social media posts. So data like that comes to us, and sometimes, well, it is nearly impossible to analyze all of that data in a more general or commonly used software platforms. And that's why we have, data warehousing, where we hold all this data and then try to make sense of it. And so I just want to give you an example of a journey of healthcare. So the history of healthcare definitely precedes 1990, and data precedes that also. But when you look at 1990, we were still doing a lot of paper-based electronic health records. And probably the biggest impact that took place in healthcare was in 2009, when the HITECH, the Health Information Technology for Economic and Clinical Health Act, mandated adoption of electronic health records in our hospital systems and providers through our physician groups. And so this created a healthcare information exchange. And then in 2015, there became this payment incentive referred to as MACRA, which is Medicare Payment Adjustment for eligible hospitals, to receive meaningful use dollars for EHR technology. If there's one thing you'll find out is technology is definitely expensive, and in healthcare, it's very, very expensive, just because we have so many systems and different data points that are coming into us. And so many rural health systems could not afford EHR platforms. So this helped them to be able to utilize EHR platforms. And the thing that is so nice about that is that now a lot of our EHR platforms, we can now share data with other health systems. And you guys, if you've been in a healthcare system that now you have a My Chart and you can put this app on your phone and you can find out, your imaging results, your lab results, even before your physician calls you. And if you forget to take that data with you, one thing about that is that, you can just bring it up and tell the doctor, yeah, here's my data, here's my information. And then you don't have to wait for that to be sent from another health system. So as you can tell, we've come a long way just in the past, 15 years in healthcare. So I just want to talk about healthcare data facts. And so these are a couple of charts that from 2018 to 2025, we anticipate compounded annually growth rate that it will be 36%. And it is going to grow rapidly over all other industries out there. So healthcare data is going to just keep growing and growing. And there's lots of reasons for that. And one of the reasons is due to digital devices. It's estimated that there will be 1,400 device interactions per person per day. That's a lot. And it's expected to grow to almost 5,000 device interactions per person per day by 2025. And most of that data that is going to be device interactions is actually healthcare related. And that's just astronomical to me when I think about it. So think about wearable devices in the past few years. You have an Apple Watch that can give you an EKG readout. You have a Fitbit, all of these things to increase healthier lifestyles. And it's not just watches. There are all kinds of wearable devices that we can wear all over our body. And we'll talk about that a little bit later. But I think it's just important to realize how much data there is in healthcare. And if you haven't realized yet, I'm kind of a geek and I like healthcare data. And I love the operational and financial aspect. And I get really excited about talking about this stuff. So one thing that I just wanted to show you, these are the types of wearable devices, fitness tracker, blood pressure monitors, biosensors, wearable ultrasound devices. All of these things are data points that are put into our system that will actually help us eventually, that we hope to give us more insight into our patients, that then we can perform better and give them quality healthcare that they need, and not too much healthcare, but just what they need. And so that's our goal in healthcare data. It's not just about finances. It's the overall. It's the big picture. And so one of the things that data analytics and how it impacts healthcare, and this is not an all-inclusive list, but patient care, it's going to help us identify risk, detect anomalies, operational efficiencies. So where are we inefficient in getting patients from point A to point B? How can we enhance patient experience? What can we do, to provide that? Revenue cycle management is a big thing for us, right? So lowering accounts receivable days, reducing manual efforts and error rates that come when you're doing manual things, claims processing, reducing denials that then have to be reworked over and over and over again. And so all of this is important to us as an organization and to give affordable health care. Supply chain management, how can we provide cost reduction through minimizing our inventory and better insights into our contract and negotiations? How can we make better informed decisions by looking at our suppliers and deciding, are you our best supplier for what we need? So all of these things are being analyzed. And just so you know, throughout a healthcare system, you have quality analysts, you have financial analysts, you'll have supply chain analysts, revenue cycle, process improvement. That's just to name a few, because there's so much data that not one of us can really be an expert in all of it. It takes the whole group to really understand what's happening in healthcare and how can we improve for our patients. This is just a subset of common data that exists in healthcare. We have financial data through clinical data that comes through medical history, diagnosis, treatments, lab, imaging, all of that data. It's going to tell us a story about our patients and how we can maybe do things better. It's integrated with our financial data so that we can make, clinical data is, more of a holistic view for decision making. Claims data, so it tells us, our billing, reimbursement. We can understand utilization patterns, costs, revenue. And then we have operational data. Patient satisfaction surveys are put into our data warehouse, and research for clinical trials, plus wearable devices that we talked about earlier. We also get data from public health records. An example is the National Cancer Institute's cancer research data. It's cloud-based. It links our data analytic tools where data is stored for genomic, comparative oncology, imaging, and other data types to really tell us about cancer patients and where are there the analytic tools might tell us the types of patients that are getting certain cancers, and based on their health data, all of that might tell us how to better take care of those patients. But there are challenges to healthcare data. There is so much of it, and we just produce so much data. We can actually have data paralysis, to be quite honest with you. And it comes from so many different systems. And probably one of the biggest things is just data formats across our systems. They're very unstructured. It takes a lot of IT resources to put them together so that it makes sense when we are looking at the data. And it's just expected to keep growing continuously, as we just talked about earlier in the presentation. It's so complex, and to make it meaningful, we have to collect the right data and have the right users. But there is so much potential with all of this data to, have an insight into patient diagnoses, reducing the cost of patient care, the quality of patient care. Are we really giving quality care? We can understand our population health, what impacts a patient could be because, they have social determinants of being homeless. That impacts their health. That impacts how we take care of that patient. So all of this is something that data is just so important to us all the way around. And so, it's just astronomical when I think about it and all the data that we collect and making use of it. But, one of the things in this, when Kinsey talked to me about doing this, I wanted to really, as an MBA student, understand more from an application. How do I use this every day? What does that look like in healthcare? So I'm going to give different examples on how we use it. And we really follow this pattern, right, that you've probably seen many times if you've been through any data analytics course. Descriptive, how many patients did we see last month? Diagnostic, why did we see the patients? And then we really want to get to predictive analytics, which patients will probably show up into our hospital next week. And if we're really good at what we do, we might be able to identify patients that should get extra treatment to prevent them coming into our hospital. Because regardless really of what people say in the media, hospitals really don't want tons of patients coming to their hospital. We want patients that come to our hospital that are sick, that really need us. When patients come to the emergency room, we want it to be because those are the patients that really need us at the time, not patients that maybe have a cold that could go to their primary care or their urgent care facility. So we really want to provide great care for patients when they need us and at the time they need us, and it needs to be cost effective. And so the biggest benefit will be in identifying and addressing healthcare providers' challenges, which also includes operational efficiency, staff recruitment, and to enhance that patient experience. So one of the things I just wanted to show you, and hopefully you can see this very well, this is data that comes from our healthcare system. And as you can tell, contract labor was very expensive for us. This is from September of 22 through January 24. We have decreased that a great deal. But if you don't know, labor is probably the most expensive thing for a healthcare system. Next to that would probably be supplies and our drug costs. And we monitor contract labor because it's such a high dollar cost. But when you cannot get staff hired, when you don't have enough nurses, when you don't have enough radiology techs in your area, you can't get them recruited. The only thing you can do is turn to contract labor so that you can take care of your patients appropriately. But when we see this data, one of the things that we do predict is talking to our staff, talking to our directors. We can predict, do you think this is going to increase next month, next week? What do you see? We know people who are leaving our health system. We try to retain those staff. And so there's a lot of HR interaction on trying to predict those things. And then also, how can we retain our staff? What can we do out of the box thinking to keep our staff here? How can we keep them happy? So those are things that we dig into when we see this cost go up. And if you look at the right side of this presentation on the slide, labor cost efficiency, we do look at that every month. Are we providing cost effective labor for what we're doing? And if not, why? And what's driving up that cost? So we dig deeper and deeper into this data to figure out what is happening and what we can do to decrease our cost. And sometimes that's using automated labor management systems to reduce management time on scheduling, to allow flexibility for staff. Sometimes we can't help it. We're short staffed, so we're having to use overtime, incentive programs. So this is a lot of information that we definitely have to dig deep into it. I want to show another example of what we look at. So we have market share data, and this just kind of tells us where are we at in our market compared to a competitor, because we just want to know, where do we rank? And so as you can tell, Baptist Health Paducah is in the orange, and we're a little bit behind Mercy Lords, which is just down the street from us. And so, we can then start digging into service lines and trying to figure out, what is it where we don't have market share? Why are we lagging behind? And things like that. But, as much as we do predictive analytics and as much as we can kind of make assumptions off of that, I want to show this gray line. Sometimes it's talking to our health partners, and we do talk, and we do have conversations. And so for Jackson Purchase Health Center, they lost market share, but we knew this was probably going to happen because they let us know, hey, we're going to have to shut down our surgery center for a while and our labor and delivery area. So in this quarter, when they dropped, we can't say, oh, we're going to keep those patients, because that's probably not going to be the case. When they open back up their surgery center, when they open back up their labor and delivery, they're probably going to gain some of that market share back. And so, analytics all comes down to, what is the data telling me? And who do I need to have a conversation with? Because the data is telling me one thing, but I really need to know what's happening inside my facility and outside my facility with other people that I work with in the healthcare industry. So we can't make assumptions. And so one of the things I wanted to show you is this lab, a service line over here. You might look at that and think, wow, what happened between FY22 and FY23 and 24? You really dropped a lot of lab visits. And so when you look at that, and we're trying to make assumptions from year to year, the reason that happened is because of COVID. And during COVID, we were still in COVID during our fiscal year 22. So every patient was getting, a COVID test. And so what happened in 23 and 24, we no longer give every patient that comes to our facility a COVID test. And so that 23-24 year is more in line with what we would have seen pre-COVID. So it's understanding the numbers, not seeing them and making assumptions, but really digging into the data and understanding what happened. So this is just a really quick slide from a net patient service revenue. And when you look at this slide, it tells me a lot about my net patient service revenue per a CMI, which that is a case mix index. That pretty much just kind of tells us how sick are our patients. And then the net patient revenue is impacted by various payers. So an Anthem may pay us for one case, the same patient or the same type of patient, same diagnosis, and we might make $10,000 off that patient, but another patient may be a United and we only make 5,000. So that's why we kind of look at patient service revenue, and that's why that payer mix is important, because we make predictions off of that payer mix. If we think it's going to stay the same, we can look at rolling 12 months. and just make assumptions. We know if we have a contract coming up and how that contract could change. So we have a lot of fluctuations that we're constantly having to really look ahead, know when our contracts come up, and then model those changes that may be taking place based on our new contracts. This here is an example of patient flow. And there are a lot of data points that you can see in here. But, you know, if you've ever been to an emergency department or was discharged from the hospital, patient flow and it can be so important, because how many of us have been to an emergency department and you're there for 3 or 4 hours or 6 hours or 8 hours? And who likes to come and stay that long? Said no one ever. And what happens when you're admitted to the hospital and going to be discharged, and a physician comes in and says, tomorrow you're going to be discharged in the morning? Or they come in the morning and say, I'm going to discharge you today, and it's 5 p.m. and you're still waiting to be discharged. Well, these metrics that we track are to actually inform us and help us. What are we doing that we are not being able to discharge our patients in a timely manner or get them through our healthcare system in a timely manner? And there's a lot in our processes that maybe need fixed. And so these analytics will tell us a lot about that. And one of the things that I can give you as an example, real life example, is, you know, in the emergency room, sometimes we can't get a patient from admission to discharge outside our room because it's taking a long time for, say, they need an x-ray. And so if x-ray is not getting their portion done, it just keeps everything else behind, or labs behind. And that could be due not to enough staffing, or there's too many patients that they're having to give an x-ray to. So there's a lot that has to be looked at through every process improvement process. That was kind of redundant, but we do have to look at that. And then we set goals, and we look at goals and benchmarking through the industry. And we're like, hey, we need to really figure out why this is taking so long to make decisions. And so we do track that. And then we work on process improvement with a process improvement advisor that helps us through those processes. And it takes a team, and it takes clinical, it takes process improvement people, it takes physicians to be bought in. So it can be a very heavy process to do that. And then here's one more slide that I want to show you. This is an inpatient encounter slide, and this is an analytics dashboard that we use. And one of the things on this is we're looking at our average length of stay. And so I know how many patients I encountered that month. And then our average length of stay is basically, it's the number of patient days divided by how many admissions that you had. And one of the things that we look at is our length of stay, and we compare it to what we call a geometric length of stay. And basically what that is something for every diagnosis related group, we call it an MSDRG, is assigned a weight, and they're assigned their length of stay. And we want to hit that length of stay. And as you can see in the red up here, we did not meet that geometric length of stay. We're in the red. And so what we do then is like, oh, okay, why are patients staying here longer? If that's our anticipated length of stay, what is causing our patients to be here for a longer length of time? Just so you know, facilities, hospitals are usually paid on what that DRG says based on Medicare, what we're going to get reimbursed for it. So if the DRG tells me I'm here for 4 days, but I keep my patient for 7 days, I still get reimbursed as if I discharge the patient on day 4. And so we will always keep patients in the facility as long as we need them. But we also have to dig into the data and say, are we not discharging patients appropriately and on time, and why? And so if you look, there's something called avoidable days by category. And if you see that, you can see our highest reason that we're not getting our patients out the door is because of financial bed placement issues. And so a lot of times what that means is that a patient is here longer because we cannot find a bed for them in what we call a post-acute care setting, which would be like a rehab facility where they need to have therapy, or say it's a nursing home. There are no beds available. When that happens, we have to keep those patients in our facility until a bed opens up or until they are safely able to go home. And that's just, we're not going to send a patient home just because we can't find them a bed. That's where they need to go. That's what we'll do. So that is something that we definitely look at. And here is just our top DRGs where we have those avoidable days, and we also look at opportunity days. And when we look at opportunity days, we may be looking at physician practice and how they discharge their patients. And we may be looking at those top service lines. Why is it happening? Talking to the physician, digging into the data, and finding out what the reason was behind all of that. Because it does just increase our days and patients are here longer. And one of the things that I would, say is that if we can decrease those avoidable opportunity days, it frees up our beds quicker so that we don't have to deny patients when we get a call from an outlying hospital that doesn't have the same type of services that that patient needs, and they need to transfer them to our hospitals. If we don't have a bed, we have to tell them, sorry, we can't take your patient today. And so that's why it is important that we make sure that everyone's goal is that we get patients discharged in a safe manner where they need to go. But if there are underlying process issues, we need to find those. And one thing you will see is every one of these charts, you can keep digging and we can actually just click on one of these and it's going to keep taking us into more data and more data and more data to look at. I know this is a lot, but hopefully you'll even have questions. So hopefully you're thinking about those at the end. But another thing that is so important in healthcare is value-based care. Value-based care is important because of its emphasis on patient experience, quality care, and the financial impact. And one thing, what is value-based care so that you understand what it is? It's basically a healthcare delivery model that providers, so that's hospital and physicians, are paid based on a patient's health outcome. So in other words, you're not paying me for just delivering a fee for service, so volume driven. It's reimbursing me based on how well I am providing patient health care and the outcomes. And the whole point of this was to set up out of control healthcare costs. And it's to shift it from volume based to value and quality of care. And it's to be patient centered. And so to get value, it's the quality divided by cost equals value. And all of this came about in 2008 when CMS, which is the Centers for Medicare and Medicaid Services, began to focus on quality patient care and health outcomes for our patients. And what happens, so every Medicare payment, by law, they withhold 2% of all of our payments. And it goes into this big bucket. And there's all these algorithms that take place. And the goal for Medicare is that every beneficiary will be under a value-based care model by 2030. And one thing that you want to know, there are tons of different value-based care programs that organizations actually participate in. And I wasn't going to go through all those. I just wanted to give you an example. But just so that you know, most healthcare systems in a value-based care model, they can be impacted by hundreds of thousands or millions of dollars a year that they do not receive because they don't meet their quality value-based care. And that basically is what this is. And this is just a value-based purchasing program that's part of value-based care. It's just one program. And as you can tell, we have to measure our clinical outcomes, and we use all of this through data. And we have to look at all of these different outcomes: patient, community engagement. We have to look at safety. Safety, we do not get paid if you come into our hospital and say you get an infection from our hospital. We have to take care of you, but we don't get additional reimbursement for, causing an infection in your body. And that makes sense, right? Because that's on us. And so this is just something that I think that, to understand, we have to earn back those value-based incentive payment percentages. And that's something that's on us, and we have to reduce, and each year we get looked at that. So each year we get a reimbursement based on what happened. And all that is data driven. So we are looking at all of these things and trying to figure out how to improve them. Data analytics, just really quick, to get a full picture of identifying patient behaviors, trends, habits, and actions. So we're using electronic health records, claims for medical and pharmacy. We're looking at health risk assessments, socioeconomic data. And then, we want to create new workflows and care models. We want to go from a reactive to a proactive, that we're already looking ahead at our patients and we're already figuring out ways so that they don't end up back in our hospital. And so that relies heavily on IT tools during the care process and analytics to provide, our change behaviors. And then we need to understand those populations, and we need to know what's a low, medium, or high risk patient, and how can we use AI to mitigate those risks in the future. And then we want to create targeted interventions to reduce that risk. And this is just something that I thought was very interesting, that is true, just from working in healthcare. We do have low hanging fruit by improving, adherence of referrals from our providers, and risk coding accuracy, those type of things. But it gets very hard when we're trying to predict healthcare risk, when we're trying to manage use a mix of our diagnostic testing, our variable costs, those type of things. And then future innovations, that you look at are, how can we prevent patients showing back up in our hospital? What can we do through our data to do that? And for an example would be, this is just a high level example. Maybe we have patients that go to a provider and they're diabetic. They can start looking at all their diabetic patients and start seeing maybe, issues with their patients around certain times. Maybe it's around the holidays when everybody's eating sugar. And we don't want them to come to our hospitals, right? Because they have an episode. So we want to maybe proactively bring them into our facilities, into the doctor's office, and really talk to them about maintaining their care during the holidays or during social events where they may actually, have an event just based on what they're doing. That's just a high level example, but those things do happen. And that's just preventable, exasperations of their healthcare. I do want to leave one of these things with you so that you can see it. Do you want to know the quality of care where you live? If you've never checked it out and you don't know where to look, you can go to Medicare.gov and Care Compare. And when you go out there, you're going to get a list of different places that you can look. You can look at hospitals in your area. You can look at ambulatory surgery centers. You can look at doctors and clinics, and they're going to give a star rating. And so if anybody wants to do that, all you do is you go out there, you choose a hospital. Well, basically what you do is you put your zip code in, and you can say, I want to look at hospitals in this zip code. And it's going to give you the star rating for all those hospitals within a certain mile radius of you. Same thing, if you want to look at ambulatory surgery centers, you choose your zip code and ambulatory surgery centers, and it's going to tell you what type of star rating that those facilities have been given. And so I just want to do a case study example for you. And hopefully this won't be like, oh my goodness, what is she talking about? It's not so much that you understand what a hierarchical condition category and risk is. It's more about the process and how we get there and the impact that it has on us as an organization and on our patients. So in part of value-based care and quality care, we have what we call a risk adjustment score. And there's these codes that patients are identified with based when they come into our hospital, and they diagnose them based on doctors' documentation, their history, what kind of diseases they've had in the past, what their health status is. And then it allows insurers to predict and allocate the amount of funds needed to care for their patients based on their comorbidity status. So a low risk is a healthier patient that will require less spend than a higher risk sick patient. And so they actually do predictive models to determine, that's where they use actuarials and all of that to determine what those low risk, high risk patients will cost them. And the risk score tells you expected health status. So this is just a partial list that I'm going to show you based on that hierarchical condition category. I think the point of our discussion is to show that there's so much data throughout healthcare to increase quality and decrease cost. And multiple methods are used to achieve those goals for greater patient safety and quality. But to do that, and it's to do this in a way that provides financial stability for an organization. So it's twofold: quality, patient, decrease cost, and bring stability to an organization. So risk adjustment, the use is to provide hospitals and providers that are going to go from a traditional fee-for-service model volume to those payments that are really based on the quality of care provided. So it's high-value providers and hospitals are always going to be rewarded with payment increases, while low-value providers and hospitals will be penalized with payment reductions. An example is another reduction program in hospital readmissions. So hospitals see a 3% reduction in their payments if we have hospital readmissions in 30 days and a patient keeps getting readmitted. So it's expected performance is calculated based on that patient risk adjustment. So it's very important that we code patients correctly. And that's what this example is about. Patients with clinical similar diagnosis are put into a condition category. And based on that, like this HCC 19, there's going to be 6 diagnosis codes. There's going to be 400 diagnosis codes in this one, and 17 is going to have 21. So it's very complicated, very detailed. And, that's why it's so important that we understand our data and what is happening to our patients. And then these coefficients are created to give us a risk score. So I want to give a case study so maybe you can understand this, and I'll show you a picture at the end. But we have a 75-year-old female, and if you read this patient has pneumonia. The patient has a cerebrovascular accident, so they have left-sided weakness, they're hypertension. This is a sick patient. They have COPD, they have chronic kidney failure. Their oxygen level was 85%. They're on a non-breather mask. They have antibiotics. They're going to require speech therapy. All of this is going on with this patient. And their risk-adjusted score was 1.285 documented, with a DRG of 195, which is simple pneumonia with comorbidities or complications. That patient is really sick. So what we find really is that this patient, there was misdiagnosis codes that needed to go out to this patient. They went from, a patient that had a simple pneumonia to respiratory infection and inflammation with major complications. And they went to, we added an acute respiratory failure. So their risk score went from 1.285 to 2.495. What does that mean for us? Well, this is what it would have went out the door. This is what, if we would have coded it this way, that patient's sick, but doesn't look too bad. And we would have been reimbursed on this less sick patient, when in reality, the patient really looked like on the right, very sick, a lot of resources to take care of this patient. And so it's very important to understand how sick our patients are. And there's one thing, if I could leave with you today, is that healthcare is not a car manufacturer where a company knows what it's going to cost to build their luxury model compared to their base model. They know in most cases, what they're going to receive in revenue when they sell that car. In healthcare, can we make predictions? Can we do it based on our contracts, what we're going to get paid based on those diagnoses? But in reality, we don't know who's going to show up in our emergency rooms. Can we predict based on history? Yes. Can we make assumptions on our patient schedules and the type of services and the insurances that we're going to get? Yes. But none of it is a guarantee, because we don't know until we start taking care of that patient what is really happening. Patients are not assembly lines. Some with the same diagnosis are going to take more resources than others. Some will have a different insurer over another. And even though we negotiate contracts, we're just going to be paid differently. We're going to be reimbursed differently based on those contracts and based on what that insurance coverage is for that patient. So hopefully this gave you a picture of the complications in healthcare and why it's so important for data analytics and try to do predictions. And I will leave you with one more: data influence governance. If I was asking a question in class and you could answer me back, I would ask, when you look at table 1, where do you think we would get more value? And so one thing about this is that for one group, reining in inpatient medical costs from their current performance um, would probably have a potential savings of $629,000. And the specialist is going to have a potential opportunity of 1.5 million. At the same time, specialist care, even though we have to understand that, we also have to understand how do we gain in those areas to help the group leadership in those areas to decide on what are the immediate initiatives that are going to drive the largest savings. So if we look at table 2, you might have thought the diabetes group because it was $1.2 million. But in digging through the data, what we might find is that congestive heart failure and COPD may be our greatest areas to focus on because those areas are driving greater emergency room visits and inpatient admissions, and our diabetes group does not. And in the long run, when our patients end up back in our hospital, either through the emergency room or admissions, that data costs us more. So what can we do to keep our congestive heart failure patients healthy enough that they don't need to come into our inpatient setting or our emergency room for care, but it's being managed appropriately on our physician side? So that can help us base our decisions on estimated results and not prone to factors such as internal politics. And sometimes you have to let the data drive that decision. So a quick recap, I think, for us is that, predictive and prescriptive analytics are a goal into providing cost-effective quality care. It's going to keep growing, and data analytics is going to grow more and more each and every year. Um, and improving patient outcomes and healthcare processes for improvement are so important to us as healthcare organizations across the country. The biggest benefit is going to be in identifying and addressing healthcare providers' challenges, which will include operational efficiency, staff recruitment, and enhanced patient experiences. From a prescriptive side, it's going to take a lot of data in usable form. Even though we're doing these type of analytics today, artificial intelligence will probably drive even more capabilities in these areas that will have a greater impact on our patients and the healthcare industry at large. But healthcare can be a slow adapter probably to AI. And there's many reasons for that. These are some of the barriers in healthcare. There's an article that came out of Healthcare Weekly maybe 2 years ago, and it said 91% of healthcare decision makers surveyed recognize the benefits of AI, but 54% of them fear AI will be responsible for a fatal error. There's numerous cases, if you Google them, where AI has not lived up to its hype. We've seen Google and Microsoft, Uber, or Tesla with self-driving accidents that were fatal. Or IBM Watson came out with an oncology program that promised to revolutionize the treatment of 12 cancers that accounted for 80% of the world's cases. But that supercomputer was still struggling to differentiate between specific forms of cancer and complaints from doctors. So how can we get AI adopted? It's going to be a trust issue for healthcare. And it's going to be a trust issue not only for providers, but for patients. So we will be slow adopters, but transparency about the benefits of the technology and how it works will be needed for patients and providers to overcome these barriers. And I think that those who can quickly and understand AI and how it can help will probably set themselves apart from other organizations and will probably be far ahead of their competitors in the future. So hopefully you've learned something today about healthcare and analytics and how it impacts decision making. But if anybody has questions, I would also like to open that up for any questions.
Thank you so much, Melissa. This has been amazing. I think we've all been patients in some capacity. Maybe not all of us have worked in healthcare, but we've all been patients. So I think it's so interesting to hear from, even wait times to offering better patient care, how data analytics can benefit professionals in this field. We did have 2 questions come through in the chat. And the first question was from Michael Thompson, amazing student. He wants to know, what ETL tools do you use to consume and process this data?
So there are different data sets, that we use. And so there's a lot of data engineering that goes into our into our data warehouse that they have to use. I'll be honest, I'm not on the IT side. just talking to IT, but they have to transform that data because sometimes it comes in an unusable form. And then once that is in a usable form in our data warehouse, it's available to us through BI tools that we have. One we use is Click BI tools. I'm not sure if you've heard of that. And so that helps us to consume that data. And then the other form that we're using today that's new to us is called Strata, and that's helping on our financial analytics side to really process that data. So I think that you'll just find different health systems are using different systems. And so it's, it's a heavy lift on IT. And so, that's how we kind of consume and process the data, are using those two main tools for us. And then quality also uses pretty much the same Click tools where the data is given to the analytics to start digging through that data. I hope that answered your question.
Awesome. Thank you. And Michael says yes. So our next question is, and I'm sorry, guys, I'm outside, so you're probably hearing all kinds of noise. Wonderful part about my job is that I get to be in multiple places at once. So is there any implementations of artificial intelligence within data collection for your current company, is what Nolan asked.
So yes, so there is some form of artificial intelligence. I will tell you probably the biggest one that's been used probably across healthcare as a whole is imaging. Imaging has kind of been ahead of the curve. There's a lot of analytics that imaging uses. So for example, I'll give you this example. You might come in, have a lung scan from a CT scan on your lung. A lot of imaging will analyze everything that's taken a picture of. So they're not just looking at the lung. But what we have found is that analytics may say, hey, I didn't find anything on the lung, but I found something of an aneurysm possibly in your stomach or in your heart. And so they really use that artificial intelligence to kind of then look at our patients and see what could be happening or going on with those patients. And you start seeing a lot of that starting to happen in breast cancer diagnoses and things like that through 3D analytics that we use. So yes, is it used? It's used a lot. I will tell you in revenue cycle management, it's probably another big user of it. So yes, it's there. We use it, but there's just greater uses for it. And so just in the past, probably 3 or 4 months, or give or take, at Baptist, we have just now started a AI governance committee that is overlooking all of our capital equipment purchases and what is the AI tools that are coming with it. What does that mean for us as an organization? How can we use it? Do we want to use it? And we have to be very careful. And the reason I would say that we are slow adapters in some ways is because we hold so much information of patients, so much of your personal information, that we want to make sure we control that data and that we don't lose control of that data. And a lot of it has to do with cyber attacks. We want to make sure, how well is this protected? How is this going to be used? And will we lose control of that data? And that's not only for our own liability issues, but it's also to make sure that we're protecting all of that information that we've been given access to, and the trust that's been given to us as an organization.
Awesome. Well, Melissa, does anyone else have any questions before we sign off? You can go ahead and unmute yourself and ask the question. If not, we'll go ahead and close out this session of Executive Insights. Melissa, thank you so much for your time. Students, thank you so much for your time. We definitely appreciate it. And as promised, this recording will be available to you probably by midday tomorrow on our Executive Insights portal. Thanks so much, everyone. Have a good night.
Thank you.